Assalamu alaikum. I'm Dr. Ahmed Lotfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and in the Middle East. My qualifications are MBCHB, master's degree, and MRCOG. This is a case of antepartum hemorrhage. Antepartum hemorrhage is bleeding in the third trimester. Case summary: pregnant woman with antepartum bleeding, uterine tenderness and irritability, painful contractions. Clinical diagnosis would be placental abruption. Differential diagnosis: placenta previa. Usually it's easy to differentiate as the placenta previa bleeding is painless, and the placenta previa would be excluded on anomaly scan at around 20 weeks. Vasa previa, bleeding from fetal blood vessels. It is a bleeding after rupture of the membranes. It is very rare. Cervical or vaginal causes of bleeding: ectropion, polyps, or infection will not be associated with uterine tenderness and or irritability. Excessive show, mucus plug with blood. Usually it is not fresh bleeding and it will not be associated with tender uterus. The risks of abruptio placenta is concealed hemorrhage behind the placenta, which can lead to maternal hypovolemia and shock, and this will lead to fetal compromise or stillbirth. This condition is associated with hypertensive disorders and or trauma. All patients with antepartum hemorrhage should be admitted to the hospital with IV access and blood investigation for blood count, group and save, and coagulation profile. The patient should be monitored with blood pressure and pulse, urine output, and fetal heart rate. Ultrasound to exclude placenta previa, not to diagnose abruptio placenta. The management: supportive resuscitation, fluids, blood transfusion if needed. Hypertension or preeclampsia should be treated with antihypertensives, hydralazine or labetalol. Delivery if TER or bleeding is heavy or continuous, or there is fetal compromise, and the delivery will be by cesarean section unless the patient is very advanced in labor. 8-9 centimeters cervical dilatation, then we can give a short trial of labor with artificial rupture of membranes. Continuous maternal and fetal monitoring is mandatory from admission till delivery and even after delivery, to make sure that the patient will not have postpartum hemorrhage. This case should be treated with senior obstetrician, senior anesthetist, and neonatologist. Key points: placental abruption is a clinical diagnosis. Blood loss may be concealed, which leads to underestimation of severity. Maternal shock signs can be delayed until major loss. All cases should be admitted for observation. This is the end of the presentation of a case with abruptio placenta. Thank you.